friends, welcome to Nursing in Health. Today I will discuss about hypertensive disorder in pregnancy. It is also known as PIH or pregnancy induced hypertension. It means the hypertension that develops as a direct result of pregnancy state. PIH or pregnancy induced hypertension also includes gestational hypertension, preeclampsia and eclampsia. Among these, eclampsia is most dangerous. Now we will know about gestational hypertension. A sustained rise of blood pressure to 140 by 90 mmHg or more on at least 2 occasions 4 or more hours apart beyond the 20 weeks of pregnancy or within the first 48 hours of delivery in a previously normotensive woman is called gestational hypertension. Some important criteria related to gestational hypertension. During gestational hypertension, absence of any evidence for underlying cause of hypertension, unassociated with other evidence of preeclampsia. Majority of cases are more than or equal to 37 weeks of pregnancy. Serum uric acid level become raised. The blood pressure should come down to normal within 12 weeks of delivery. What is preeclampsia? Preeclampsia is a multisystem disorder of unknown etiology characterized by development of hypertensive phase to the extent of 140 by 90 mm of Hg or more with proteinuria after the 20th week in a previously normotensive and non-proteinuric woman. Risk factor of preeclampsia: primary gravida, young less than 18 years and elder above than 35 years, family history of hypertension and preeclampsia, placental abnormalities, placenta ischemia, obesity, BMI more than 35 kg per meter square and insulin resistance, pre-existing vascular disease, pregnancy following ART or assistance reproductive technology, abnormal blood clotting disorder. Etiological factors of preeclampsia: failure of trophoblast invasion, abnormal placentation, vascular endothelial damage, inflammatory mediators or cytokines, immunological intolerance between maternal and fetal tissue, coagulation abnormalities, increased oxygen free radicals, imbalance of angiogenic and anti-angiogenic protein, genetic predisposition, dietary deficiency or excess. Next, alarming symptoms of preeclampsia: headache, reduced urine output less than 400 ml in 24 hours, epigastric pain, vomiting, blurred vision. Signs of preeclampsia: abnormal weight gain, more than 4 pounds in a weeks in later month of pregnancy, increased blood pressure more than 140 by 90 mmHg, edema, fast occur, slight swelling over ankle, tightness of the ring on the finger. Next, gradually the swelling may extend to the face, abdominal wall, vulva and At the last time, generalized edema may occur. Pulmonary edema also can occur. During abdominal examination, growth retardation of fetus is found. How can we prevent risk factor of preeclampsia? Regular antenatal checkup for early detection of rapid weight gain and increased blood pressure. Exercise, stretching and physical activity and yoga. Use heparin in case of high risk pregnancy. Take calcium supplementation and calcium rich food. Take antioxidant. It includes vitamin C, E and other nutritional supplementation. And also take magnesium, zinc rich food and take low salt diet. Maintain balanced diet rich in protein, etc. Management of preeclampsia. In case of preeclampsia, take adequate rest and take low salt diet and hypertension preventive diet. Use diuretic and antihypertensive medicine as per doctor's prescription. As you see, increased blood pressure during pregnancy must contact with doctor and gynecologist. Next, we know about eclampsia. Preeclampsia, when complicated with grand mal seizure or generalized tonic-clonic convulsion or coma, is called eclampsia. Risk factor of eclampsia: unknown etiology, previous history of hypertension, priming of the mother, family history of eclampsia and renal disease. Next, clinical features of eclampsia: severe headache, high blood pressure, proteinuria, weight gain, vomiting, coma or unconscious stage. Stage of eclampsia: premonitory stage, tonic stage, clonic stage and stage of coma. Prevention of eclampsia: use of antihypertensive drug, prophylactic anticonvulsant therapy, timely delivery, close monitoring during labor and 24 hours of postpartum period. Prophylactic use of magnesium sulfate. Next, management of eclampsia. Supportive care for prevention of fall injury, aspiration, maintain airway and oxygenation. For supportive care, patient should be kept in a rail cot. Use tongue blade inserted between the teeth when convulsion occur. Provide lateral decubitus position to avoid aspiration. For monitoring oxygen saturation, use pulse oximeter. When oxygen saturation falls below 92%, ABG or arterial blood gas analysis should be done. And if blood pH is below 7.10, sodium bicarbonate should be given. Regular monitoring of pulse, respiration and blood pressure for any changes of patient condition. Maintain fluid balance. The total fluid should not exceed the previous 24 hours urinary output plus 1000 ml. Next, use antibiotic and administration of magnesium sulfate. Regimen of magnesium sulfate for management of severe preeclampsia and eclampsia. Loading dose: 4 gram 20% solution IV over 3 to 5 minutes and deep IM 5 gram in each buttocks. Next, 4-hour interval maintenance dose: 5 gram 50% solution IM 4 hourly in alternate buttocks. How can you detect magnesium toxicity? Loss of deep tendon reflex, decreased respiratory rate less than 16 breath per minute, urinary output less than 30 ml per hour, chest pain, heart block pulmonary edema, oxygen saturation monitoring, partial pressure of arterial oxygen less than 95%. Management of magnesium toxicity. To stop magnesium therapy, estimation of serum magnesium and creatinine level, injection of calcium gluconate 10 ml 10% solution, IV slowly.